just going to talk about anatomy real quick, and then I'm going to show you some pictures. Normal anatomy, located mid portion of inferior cricoid cartilage, obviously, so it's under the cricoid cartilage, and then these are the boundaries. So this is going to help you out when you look at it on an ultrasound. On the laterally, you're going to have your sternocleidomastoid muscle and the carotid sheath. Anteriorly, you're going to have your strap muscles, which you learned last unit, your sternohyoid, sternothyroid, and omohyoid. And then posteriorly, you're going to have longus colli muscle. Posterior medially, you're going to have the trachea, and the esophagus is going to be behind the posterior lobe of the left thyroid lobe, posterior to the left thyroid lobe. And if you, like when you're doing an exam, like if it's live, you can tell them to swallow and you can differentiate it that way. Okay, so like I was saying, as you can see, laterally is the sternocleidomastoid muscle. Anteriorly, you have the strap muscles, and then it's inferior to the cricoid cartilage. And then the carotid sheaths are laterally. Okay, so this is an axial view. Once again, you have your sternocleidomastoid muscle and your strap muscles, and then this is the thyroid gland. And in here, I know it shows the esophagus right posteriorly, but it's actually more posterior to the left lobe. So it's a little bit, it would be like around here. Okay.
Wouldn't that be the right side?
It would be, I mean, if you're looking at it from the feet up, the right side would be, this is
Oh, I'm looking at the feet. Okay. Yeah.
right. So, and then these are the carotid sheath laterally. Okay. So here is the same picture on an ultrasound. This is the, what do you think this is, Kenny?
Trachea.
Probably, yes. And then right lobe, what is this? What's this area called?
Oh, isthmus.
Yeah, good. And then laterally, what did I say was here?
Sternocleidomastoid.
Right. And then the strap muscles are here. Carotid sheaths even more laterally.
Mm-hmm.
Okay. And then the esophagus is probably just around somewhere here.
Right.
This right here is a, let's see, hold on. This is a, okay, so this is just the left lobe. So it's like one side of it. And then as you can see, this is the esophagus. So it's just basically that same thing, but just cut off in the middle, more focused on the left lobe. And the esophagus is here. What are these two?
Carotid and that's jugular vein.
Mm-hmm.
I think.
Yep. Yeah. And then this?
Sternocleidomastoid.
Right. And then this would be, what is this then? Oh, shoot.
That. Beats sternohyoid, sternothyroid. I don't know. One of those.
It says SM, so let me just double check that.
That's all good, man. That's last unit stuff.
Yeah, but I just wanted to like differentiate like what's where. I'll get back to you on what exactly that muscle is. But there's another muscle posteriorly, it's because the longus colli muscle. I don't know if you can see it. I think it's right here, this muscle.
All right.
And then SM, what could SM be? I'll get back to you on that. But that's that muscle right here. Okay, so this is a sagittal view. Oh, let me move this. I feel like our screen is on the way. Bam. Okay, so this is a sagittal view.
Oh, there's that. Your mic is making that sound.
Oh, how about now?
And not so much. Less, okay.
Yeah. Okay, so this is a sagittal view. So this is taken like this way. You get what I'm saying? And then the axial views are taken this way. So on thyroid exams for ultrasound, it's going to be only these two views. On sagittal views and axial views, no coronal views. And I just wanted to show how the transducer is placed for each. And then we just went over the anatomy. So I'm just going to go over the sagittal anatomy, which is, so this is thyroid, and then you have your strap muscles in the front, and then the trachea in the back. Good?
All right.
And then I think this is the longus colli muscle.
Okay.
And okay, so image acquisition. So whenever you take the picture, you want to measure three things. You want to measure length, width, and depth. The length, what do you think is the best view to take a picture of the length or measure the length?
It's a sagittal, so I guess sagittal, man.
Yeah, and then width and depth.
The axial.
Right, perfect.
Mhm.
Okay, and then just showing the transducer placement once again. Okay, so now we're just going to pathology. So thyroiditis is just normal thyroid parent. It's like, how is it different from normal thyroid parenchyma? So normal thyroid parenchyma, it's going to be homogeneous and hypoechoic when you compare it to the strap muscles or muscles nearby. So just remember, normal is supposed to homogeneous. It's supposed to be homogeneous. It's supposed to look the same, same color, content, same texture. And then as
Mhm.
far as the intensity, it's supposed to be hyperechoic. But in thyroiditis, you're going to have heterogeneous, so it's going to be patchy. It's going to look like it has multiple different textures. It's going to be hyperechoic and hypoechoic mixed up. And it what it's showing is like what's going on actually with the pathology underneath, which is infiltration of lymphocytes and fibrosis. So it's not going to be same smooth normal anatomy. And then the size is just going to depend on how long this has been going on. So with thyroiditis, these are the two things you definitely will see. It's going to be heterogeneous with hyperechoic and hypoechoic areas. And yep, that's pretty much it. And the size.
Okay.
So like, what view do you think this is, Kenny?
Go with sagittal.
This is sagittal. And how does the thyroid look?
It's pretty heterogeneous to me.
Beautiful. Nice, nice. Okay. All right. And that's all I wanted to take away from this. And then the trachea is somewhere under here. Okay. Just so behind this. And then it's like, you see how it kind of like makes this wavy appearance?
Right.
You know why that is?
Let me think.
Okay.
No, I had no idea why.
It's because of the tracheal rings and how they're only present in certain areas. So that's why
Yeah,
it makes it look like wavy like that. It's not
that makes
all
sense.
across. Okay, next we're going to talk about thyroid nodules. So with thyroiditis, just take away, it's supposed to be heterogeneous, and yep, that's pretty much it. And also, we'll talk about vascularity next when it comes up. Thyroid nodules, we want to evaluate these 5 things. So whenever you look at an image and you find a thyroid nodule, just go through how it matches up in these 5 categories, because that'll tell you whether it's malignant or not, or it leans more towards malignancy or not. Then if it does lean more towards malignancy, then you'll have to do a fine needle aspiration. Okay, so echogenicity when it comes to thyroid nodules. Sorry, did you say, do you have something to say?
No, I
Okay.
get.
And then, so echogenicity, brightness of thyroid nodules in comparison to normal thyroid parenchyma. And just remember this, just put this in your head. If you see a nodule and it's hypoechoic, it's bad news, most likely. Hypoechoic nodules are not good. It's associated with malignancy.
Okay.
So as opposed to, you see like in here, this is a axial view or transverse view. This is a big thyroid nodule in the middle. And it's, would you say it's hypoechoic, hyperechoic, or isoechoic, Kenny?
To what? Just the surrounding?
The surrounding structures. Is it really hypoechoic or just kind of like, well, actually, it says
Kind
it right
of.
there.
A little bit hyper, I think.
This one, the one on the left?
Yeah, man.
Yeah,
No?
a little bit hyper, but mostly like isoechoic, not dramatically hypoechoic,
Oh, yeah,
hyperechoic,
yeah,
right?
yeah,
It's
yeah.
not like this.
Yeah,
Yeah,
yeah, I'd say it's
yeah,
isoechoic.
yeah. But how about, so this one, can you orient yourself where you're at on this side, right here?
Hmm. Let me think.
What view is this? Like, what plane?
This view. I'm gonna guess it's axial, but I'm not
Okay.
sure.
And then which lobe is it, right or left?
I think it's the right lobe.
Which, it's, so what is this?
That's a trachea, right?
Okay. And then this is on the,
That's the right lobe.
Right. Okay. Good.
All right.
And then this is the cyst, and how does it look?
Hypoechoic.
Hypoechoic, right? And what do
Yeah.
you think these two things are right here?
Vasculature.
What specifically?
Common carotid and jugular vein.
Which one's common carotid? The smaller one or the bigger one?
That's a good question. I think the common carotid is more medial. So
Right. Smaller one.
yeah,
Okay.
or
You
smaller
got
one.
sternocleidomastoid here, strap muscles. That's what SM was, strap muscles.
Ah.
Okay. Next, we already looked at echogenicity. Next, we want to evaluate the structure of the nodule. And if it's a pure cyst, like if it's mostly like fluid, and remember I talked about posterior enhancement with fluid,
Mhm.
as you can get with like bladder or gallbladder, just with fluid. So if it's pure cyst, pure fluid, it's most likely benign, but mixed cystic and solid nodules are more towards malignancy. So if you have an area or a cancerous area and you have central necrosis, it's gonna have slightly hyperechoic area, but it's gonna have a central hypoechoic area. Do you understand what I'm saying in the nodule?
Can you repeat that?
Yes. So if it's like sometimes with certain cancers, I think we learned this in unit 1, in like
Mhm.
towards the center of the nodule, sometimes it
Mhm.
dies and necrodes.
Okay, yeah.
There's
It's like
necrosis, right?
ischemic there.
Yeah, so if it's like a nodule and it's solid, but there's like central necrosis, then it could be malignant because that central necrosis is associated with malignancy.
Okay, gotcha.
Okay. All right.
Mhm.
So here, these are most likely completely fluid filled,
Mhm.
and you have some like posterior enhancement, and there's not really a solid nodule with a little bit of hypoechoic area, right? It's the opposite. You understand what I'm saying? It's mostly fluid
Yeah.
with some like maybe calcifications in the middle, but it's
Okay.
mostly fluid filled. I'm going to talk about calcifications later.
Mhm.
And then, so in here, as you can see, it's like mostly a cyst, right? And there's a
Mhm.
solid component in the middle.
Yeah.
But in here, you have a cyst and you have a solid component, but then you have a cystic area in the middle, right? Like kind of like a
Mhm.
honeycomb appearance. So what I just want you to take away is that if it's mostly cystic, then it's most likely benign. But if it looks like a solid nodule, like kind of like this, and there's areas in the center where there's little areas where it's hypoechoic, then that could be more towards malignancy.
Mhm.
Pure fluid in a cyst, most likely benign. Okay.
Right.
Next is calcifications. So microcalcifications without acoustic shadowing. Remember when I talked about acoustic shadowing?
Mhm.
It's like the
Yeah.
opposite of acoustic enhancement, right? So these are not like really big calcifications. It's kind of like small calcifications where it doesn't have that posterior acoustic shadowing. So it's like really small, like less than 1 millimeter. These
Mhm.
are associated with increased risk of malignancy. Big calcifications, not really. Because do you remember Samoma bodies in papillary thyroid cancer,
Mhm. Yep.
right? And then it has those concentric lamellar calcifications.
Yeah.
So that's what there's. So if there's like small calcifications like that in the center, it it could lead towards, or it could lean towards malignancy because they could represent those Samoma bodies.
Uh,
You're with me?
so mama bodies were calcifications.
Yeah, those little circles, those are
Yeah, I remember the little circle.
fibrosis calcifications. Yeah.
I.
Okay. So if you see, as far as like if you like, it says less than 1 millimeters, right? So this is a mix of both. I'm talking about like calcifications, like pinpoint calcifications, like this. Those
Mhm.
are more worrisome.
All right.
Okay. So little
Mhm.
tiny calcifications. Especially if you see something resembling like lamellar calcifications, it's most
Mhm.
likely malignant. And then vascularity, there's 3 types of vascularity, okay? So you have absence of flow, which is type 0. We're still in the realm of nodules, okay? So I'm talking
Mhm.
about within the nodules, there's absence of flow, type 0. That's most likely something like if it's just fluid inside, it's going to be type 0. Peripheral flow, it's a cyst, and it has blood flow around the periphery of it. I'm going to show you a picture. And intranodular flow is like if I'm getting blood flow inside the nodule. And intranodular flow has especially if it's a nodule, intranodular, I mean, it's in the name, but if there's blood flow within the nodule, in the center of it, it's an increased risk of malignancy. So you have one nodule with a peripheral blood flow versus a nodule here with blood flow inside of it. So the one with the blood flow within the inside are more associated with malignancy. Now, what view is this, Kenny? What plane is this?
Oh, that is an axial view. Man.
Okay, and the one on the right?
That's a sagittal view.
Nice, nice, nice. Okay,
In here.
all right. And then we're pretty much done here. So we got a case, all right? Can you read the case for me, Kenny?
Okay. Case presentation. A 33-year-old man with no significant past medical history
Louder.
presented. A 33-year-old man with no significant past medical history presented for further evaluation, abnormal thyroid function test. He was seen by his primary care physician due to fatigue, weight loss, palpitations, diarrhea, and anxiety. His physical exam is notable for thyromegalia, thyroid root, tachycardia, brisk reflexes, and tremor in his hands. Blood work reviewed elevated free T4 and suppressed TSH consistent with hyperthyroidism. The differential diagnosis for hyperthyroidism includes Graves' disease, thyroiditis, and hyperfunctioning hot thyroid nodules.
All right. So what are you leaning more towards, Kenny?
Let me see.
First of all, is it hyper or actually it says that on there? Hyper, hypo.
It's hyper.
Right, because of the weight loss palpitations.
Yeah.
Up down I don't know if they said that. And then the brisk reflexes, right? And
Yeah.
So our differentials are Graves' thyroiditis or hyperfunctioning thyroid nodules. So if it's thyroiditis, then it has like a brief period of hyperthyroidism. Then it kind of declines. And then Graves' disease, you have those antibodies. And then hyperfunctioning thyroid nodules are just hyperactive thyroid follicles. Okay. So this is what we have on the image. It's a longitudinal view of the thyroid gland. Shows. Okay, so what do you see, Kenny? Don't read the thing. Try not to.
Looks heterogeneous.
Right off the top, not heterogeneous at all. Right, and then what did I say? What makes that? Gives it the heterogeneous appearance? Like what's going on inside of the tissue that gives it that? Do you remember? I said it maybe too quickly.
Did you?
Was it?
I want to say no. I don't remember.
Lymphocyte infiltration, right?
Oh.
I said that, right?
Maybe. I'm not sure.
Yeah, lymphocyte infiltration. That's what that presence. And then any nodules?
Nodules. I thought I saw one.
Which one?
All the way in the bottom. I thought that was a nodule, but
this right here.
Yeah, I thought that was a nodule.
Yeah, this could be just like signal loss or just the trachea, because I think this might be one of the tracheal rings, but most of it is signal loss. I wouldn't worry about it. If there's it most likely would be in the middle. All right, so this is so what kind of blood flow? First of all, there's no nodules, right? And that's those three types I mentioned. Those are for like nodules, like intranodular, peripheral to the nodule, or no. So this is like more. But what do you see just off the top?
It's a vascular storm. Is that the term?
Yeah, there's like a lot of blood flow going on, right?
Yeah.
So now, like that, you saw both. Our differentials were like Graves, Thyroditis, and the last one was hyperfunctioning thyroid nodules, right?
Yeah.
So what are you leaning more towards now?
Well, you told me there's no nodules, so I'm not going with that. So then I got thyroiditis and then Graves, and you told me that those heterogeneous is lymphocytic infiltration, so that makes me think Graves.
Okay.
Yeah.
All right. Good. But remember that with Graves, There's also what's causing the things is antibody infiltration also.
Uh-huh.
So it could also give that heterogeneous appearance.
Oh,
So
you can't tell me.
yeah.
It's not
So
great.
so thyroid ultrasound exam reveals an enlarged thyroid gland with diffuse heterogeneous echo texture, significantly increased blood flow on flow Doppler throughout the gland, and then these are the lobe measurements. That's not very important. So this is, let's see why it's specifically thyroiditis. And so thyroid ultrasound findings consistent with Graves' disease include increased gland size, heterogeneous echo texture, increased vascularity. Visualizing significantly increased vascularity with color flow, Doppler ultrasound is similar to auscultating a thyroid bruit, a very specific physical exam for Graves' disease. I think I've seen that before. Like people say they hear a carotid bruit, but it could be from the thyroid, from the increased blood flow.
Okay.
I've seen that come up like on questions and stuff. But I think with thyroiditis, maybe the gland wouldn't be bigger. I think it's still the three things that narrowed it down to gland. I mean, not gland. Graves' disease was the increased gland size, heterogeneous echo texture, and increased vascularity.
Okay.
Like, but I see what you're saying. It could, because what did I say? Can you tell me off the top, like what are some of the things that makes it malignant? Just one.
Vasculature through a nodule.
Like, yeah, first of all, it has to be like a nodule, right? And then what about the vascularity?
It's going through the nodule, right?
Yeah, intranodular blood flow.
Intranodular flow, right?
How about echogenicity?
Oh, hypoechoic.
Hypoechoic, right? How about calcifications?
Microcalcifications.
Microcalcifications. And then as far as structure, cystic, solid, what's more like leaning towards malignant?
Solid.
Solid with
Central
central
hypoechoic.
Yeah, and why is that?
Because there's no blood supply there. Wait,
It's like, yeah, because some of the like cancerous tumors are associated with central necrosis, right? Right. And then those calcifications could represent what?
Some MOMA bodies.
Yeah. Okay, that's it. That's it.
Okay.
All right, everybody. Short and sweet. I know everybody's busy. It's like exam time, so I wanted to keep it short. I'll make one on the pelvis stuff pretty soon. All right, take care. Bye.
How long was that?